So the METIF trial investigated tivantinib, which is a MET inhibitor in patients with HCC and previous treatment with sorafenib. So the study was quite interesting because in the patients there was a biomarker-driven study because we had the biopsy we had tested for MET, and only in patients who had a high MET expression, the treatment with tivantinib was started. It was a placebo-controlled trial, so it was 2-to-1. However, even it was a biomarker-driven study, the study was negative. So there was no improvement in overall survival in the patients who received to placebo. And I think there are some critical points concerning the study. I think there was one critical point. So within the study, they had to decrease the study amount of the drug because they had severe side effects, which they didn't expect it. So neutropenia was a problem. And the second one, I think it wasn't really good to do the biomarker testing. It was not standardized. So you could do the biomarker testing from really old biopsies, which had been before start of first-line treatment, or really fresh biopsies. So maybe this may be biased the study results. But in the end, it was not active. And we also saw it in gastric cancer. We had also MET inhibition with antibodies or small molecules, and there was no improvement in overall survival in patients with gastric cancer. So just targeting MET without targeting other kinases, it's probably not the best way to go.
In second-line treatment, we have now one drug available that has been shown efficacy after failure of sorafenib. The trial was a very well conducted trial with very specific inclusion and exclusion criteria. And one of the inclusion criteria was that patients need to progress on sorafenib, and they were required to tolerate sorafenib for at least 4 weeks. So patients that did not tolerate sorafenib were not candidates for this trial, indicating that we have now really a specific population of patients that are used and tolerate tyrosine kinase inhibitors, and also, very importantly, that do have a good liver function because only Child-Pugh patients were included, so that they were able to participate in this trial. When patients fulfill these requirements, they have a really very good prognosis or success with the treatment of regorafenib. So median overall survival was increased by almost 3 months, which I think is a very good result in HCC in second-line treatment. And it was clearly a positive trial. So this is very good news. And from my own impression, if we really stick to the in- and exclusion criteria from the clinical trial, also in clinical practice, regorafenib can be very good tolerated by our patients. So we have used regorafenib in colorectal cancer, and it was really sometimes very difficult to manage all these side effects. But my impression in HCC was that patients that tolerate sorafenib also tolerate regorafenib. Even in the trial, there was, of course, also quite a number of side effects that occurred. But in daily life, so my experience is that regorafenib is very well tolerated, and we also see responses with regorafenib after sorafenib. So I think it's a very active drug and a drug that we clearly can use in these patients that reflect the patients that have been included in the clinical trial. The concern and the highest unmet need is that most patients that get to second-line therapy are no longer Child-Pugh. And this brings me back to the point that we really need to monitor liver function during our treatment. So we can use all these local therapies, but we need to carefully monitor a liver function. We need to see that we do not harm the liver and that we stop the treatment once we see a decline in liver function. First line, we have most likely 2 options available in the near future. And then again, we should not continue with treatment beyond radiological progression, for example, because now we have effective drugs in second line. So I think the management of HCC will change with the approval and the most likely approval of the drug that has been positive tested in these recent phase 3 trials.